thank everybody for coming here tonight. I know everybody's busy with schedules, school's back in session, there's kids' activities, so I really appreciate your time and effort to make it here tonight. My name is Karen, and I'm the network provider administrator, and so I'm on the network side, the provider network, and we'll get into a little bit about that. But I have my card out on the table, so if you want to grab that on your way out, or you grabbed it, if you have concerns or questions, feel free to give me a call. Just about a little bit about the agenda today. So Mission started in January of this year with a partnership with St. Vincent's. And so we're going to talk a little bit about that and give an overview for those that Mission Point is new to you. Some of you have been around and have heard the Mission Point story, but want to give that opportunity for those that haven't. Before we do that, though, we're going to look at, where is healthcare going? We know there's a lot of quality metrics going on in Medicare and in our traditional payer insurance world, employer groups, and so we want to talk a little bit about that. And then where does Mission Point fit into that mold? We'll also look at clinical integration because that's what our model is all about. And then also follow up with clinical performance and where we're looking to be and where to go in the future here. So I'm going to go ahead and turn it back over to Dr. Swinney, and he's going to talk about where healthcare is headed.
All right, thanks, Karen. Okay, so as I think most of you are aware that the times they be a change in terms of the way payments happening and the way payers are responding to the increasing healthcare costs that we're seeing. This slide basically illustrates what CMS has told us that they plan to do. The targeted percentage of Medicare fee-for-service payments linked to quality and alternative payment models between 2016 and 2018. So CMS has signaled that there's going to be a significant increase in the amount of risk-based care that's provided out there. Currently in 2016, the dark blue circle represents 30% of alternative payment models currently in place. So CMS has said that that's going to grow from 30% up to 50% over the next 2 years. Significant increase in the number of things like the Medicare CHIP savings plan that we're going to be talking about tonight. So St. Vincent recognizes that, Ascension recognizes that, and so we're all in to try to keep up with that change to prepare ourselves. As you know, it's not just CMS, it's the other payers as well. So, in terms of where Mission Point fits into that, currently what we're good at, this is the medical care that we currently provide is what we've done for years. So, handling acute care, dealing with health outcomes, quality of life, stuff that we've all been accustomed to. Where Mission Point, what we're going to talk about tonight, is focusing on things that related to health promotion, prevention, managing care, managing transitions of care. So you're going to see tonight a lot of the things that Mission Point we think has to offer in addition to the models that we've already had that can improve the quality and then also the cost of care that we're providing to our patients. So, it's no surprise, I think, to most of you that know that the price of healthcare is far outpacing inflation and wages. The bottom two lines here the bottom line represents current inflation rates over the last 15 years or so. The second line just above it is wages, so wages going up a little faster. But when you look at the incremental increase in healthcare costs, the top line represents what people are actually having to pay. So you can see that it's far outpacing the rate that wages are going up. Consequently, CMS, the government, as a payer as well as private payers, are saying we got to do something. And the way that they're going to do that is by taking the risk and putting it basically on the providers. Mission Point at St. Vincent in our ACO and the value-driven system is about how do we do that in such a way that we can provide a better product. We think that if we do provide risk, that we can do that we can provide a product that's as good a quality, if not better, but at a price that's better than we've been able to provide it before. So with that, Karen's going to come back up and she's going to talk to us a little bit more about Mission Point.
So when we look at Mission Point, there are three particular components that are important in Mission Point. Number one is we have to have a physician network. So we have members that we serve, and we have to have a physician network built in order for those patients to go see their physicians. So that's number one. Number two is we have clinical health partners, and I have three sitting over here to my right that are going to get up and talk in a little bit about all of the great things that they're doing to work alongside the physicians to increase the patient care that we serve for them. And the third piece is our Crimson Analytical tool. That's the tool that we have. We have three different modules with that. One of the modules the health partners use to input data into that to actually get feeds from the hospitals when members are going to the hospital or they end up in the ER. They get a direct feed to start contacting those members to address whatever their concerns or needs might be. We also have a stratification tool so we can look at the risk of some of our members. There's rising risk and there's high risk, and then there's our well members, and we want to take care of those too. So through this system, we're able to address some of those things, as well as looking at how are we doing on inpatient stays, how are we doing with readmissions, how are we doing with ER visits, and kind of bump that up against the benchmarks that our other Mission Point markets have, as well as the national benchmarks. So those are the three components that we'll get into this evening. And this next slide just gives you a picture of Mission Point itself. They first started and were founded with St. Thomas in Nashville, and that's where they're located today. So their headquarters are in Nashville, but we do have 5 new markets that started in 2015. In addition, Ascension, they solely are owned by Ascension in January of 2015. So we've grown rapidly in the past few years. When Mission Point first started in Nashville, they achieved savings that first year, and so I think that set the tone for the other Ascension hospitals as we move forward to have that same success. We also have a Kohl's distribution center on the west side and then also in Texas, and so member services are actually scheduling employees to go to those clinics in those areas as well. So the spend healthcare keeps going up. The number of providers that we have in Mission Point keeps going up, and we continue to work on our population health strategies. So where are we today? And we're in Indiana, so that's our new market that we have. Nashville has a variety of populations that they serve. For Indianapolis, we chose to start with 2. So for the independent docs, your target market is the self-insured. And right now, that is the St. Vincent's Associates and dependents that are in through Smart Health. It is the goal that we'll continue to grow and add employer groups as we get our feet wet here in Indianapolis. I envision probably by 2017, we'll have more employer groups added outside of St. Vincent's Associates. But right now, that is our employer group that we're focused on. And then for St. Vincent's Medical Group, they actually have their own ACO as well, and so we're managing those lives as well. And the health partners are seeing Medicare members, the traditional members, as well as the St. Vincent's Associates. So when we look at that, we had to build a network. And so back in July, I wasn't here yet, but back in July they started building this network. They took a look at the claims experience in the past, looked at it, some analysis to determine, who do we want in that preferred network? Who do we want our members going to see? We want high quality physicians. We want physicians that are keeping things in network. We want to make sure that we have physicians that are really driven on population health strategies and clinical integration and looking at reducing our cost but keeping the quality up. And so in January we went live and we have about 2,500 providers right now in the network. We have 158 provider groups, and then we also have about 94 different specialties. And that's through the whole state of Indiana. And so as we kind of get started and members start going to their physician, I get these calls and they'll say, I'm supposed to be in this Mission Point thing. I'm not sure what it is, but I'm supposed to be in it. And so then I'll go out and start contracting with them. Or we may have a need or a gap somewhere within the system that I will go out and start contracting. So the network is never closed per se, but we do want to keep it narrow because we want to be focused on those positions that are high quality and are here to keep things within the St. Vincent system. So I continue to work on contracting for ancillary providers, SNFs, behavioral health as well, as we continue to mold that network. Any questions so far? One too fast. I'm going to turn it over to Jeff. He's a health partner, and they've just done so much great things in the past 8 months since we've started, and I thought it was important that he be able to share that himself. It's very personal to him, so I'm going to go ahead and turn it over to Jeff.
Thanks, Karen. Good evening, everyone. I'd like to introduce, I'm Jeff Collins. I'm a lead health partner, a registered nurse at Mission Point. Work right here in Indianapolis, right over here on Nab Road, 8220. So I want to start, I want to start with this slide. What are our 4 aims? What are we doing here? So the primary goal is to reduce the overall, or improve the overall health status of our community. It's kind of backward, right? We used to be in sick care, but now we're looking at reducing costs. So improving the health status. So the slides are, I think they're a little different. Our first aim is to improve the health status of our community. And we improve the patient experience by preventative care, acute care. So we're intervening in people's lives at their probably some of their most vulnerable times and helping them navigate this, I mean, heard that word before, but help navigate these kind of tough times. And then if we're helping your patients navigate, this difficult time, we're actually enriching your lives. And so, thus reducing the overall healthcare costs naturally. But that's not our first and primary goal. We're looking for the poor and the vulnerable, people that don't make good decisions in this world, and those people are often the ones that cost a lot of money, a lot of healthcare dollars. And so we use the Crimson tool to identify those people at risk. As you've probably heard many times before, 1 to 5% of our population is comprising a lot of our healthcare dollars. And so we label these as high-cost members, and we're really attacking this stratified patient section. So we're stratifying off of risk, and then we're assigning health partners based on that stratification. So our high-cost members, we're paying very close attention to, because that's where we can reduce the biggest amount of money. Of course, there's the rising risk members of our population. This is where it's just kind of really neat because, these metrics and this data and all these number crunching, they can actually predict, based off of comorbidities, patient visits, and, all of these neat things. It's a pretty powerful tool. It's predicting that these people are going to move into a high-risk category. And so we're assigning them health partners. And then you kind of move down the pyramid a little bit, and the at-risk members, okay, so they're at risk, maybe they went to the ER, maybe they had an inpatient stay. So these are the people that potentially in their lives could make bad decisions, from this point. That's where we intervene. Okay, well, you got a new diagnosis of diabetes. What are you going to do about that? You got CHF. Who are you following? Are you doing the things in your life that you're supposed to keep you healthy? And then finally, there's the people that you probably see on a daily basis, and those are the people we're very interested in as well. And I think if you take away anything from today, is that it's very difficult to reach, connect, and build a trusting relationship with people you don't know. And so there's a lot of credibility that comes from you all. If you tell a patient, your patient, I'm going to refer you to Mission Point, and they're going to give you a call. That patient immediately recognizes that we're going to call them, and that's a huge amount of credibility. There are stories upon stories that we have made a difference in people's lives and really affecting the overall health of our population. Our numbers are pretty neat, but we don't have a lot of numbers just yet. I will speak to this. That's a lot of numbers, but the slide really doesn't mean anything. Just draw your attention to this 5%. It's comprising 66% of the total healthcare costs. So there's a lot of room for improvement here. We can make a big difference. So, if you have someone in your office that, I don't know, maybe referral. We want the referral. We put your referral in very, very, very high regard. Personally, I have a card right over here next to my computer. Feel free to grab it. And I will turn it over to the beautiful young Miss Jane Edwards.
Hi, my name's Jenny, and I work with Jeff and Amy here in Indianapolis. My background is 28 years of emergency nursing for a different healthcare system. When I heard the opportunity that heard a little bit about Mission Point, I really didn't understand it or didn't know what was going on, but I jumped in with both feet and haven't looked back. It's a really neat model. So what this slide kind of demonstrates is they kind of came up with a 3-team approach. They thought we've got to meet all the needs of our members, patients. People have different needs when they're inpatient and they're going home. They have different needs when they're managing chronic disease. And there's the psychosocial needs that can be a real barrier to healthcare. So they came up with first as you can see, the transition team. It's a group of nurses that will get the feed, as they talked about, that there's an inpatient admission. So they immediately are notified of the feed and what facility in the St. Vincent network. They will make a bedside visit, introduce themselves, explain Mission Point, and then immediately upon discharge, they will follow that member for 30 days. They can do home visits. They can go to doctor's appointments with them. They can help them make the follow-up appointments. Oftentimes, when they're sent home on discharge medications, there's a lot of questions, confusion. They still aren't feeling all that great. They can go over all their medications with them. So it's just kind of a neat tool to ensure that, obviously, prevent readmission, to just connect with them to make sure that they do stay healthy. The second part of the model is the ambulatory team, or we kind of can manage chronic disease, or we can manage wellness. We get our feeds, we usually meet folks when they have an ER visit. So we immediately get the feed, we can call them, kind of just check to see how they're doing. Do they have any questions? Were they able to get their medications filled? Do they have a PCP? Things like that, just kind of intervene in their lives to make sure that they have all their needs met. Oftentimes what we find out is their psychosocial needs. They keep going back to the emergency department because they didn't get their antibiotic filled because they can't afford it. And in talking with them and reaching out to them, we're able to kind of delve into those little barriers, and that's when we can bring in our third model is our integrated care team. Sorry. These are licensed therapists, counselors, and social workers. They are just phenomenal. They have resources that they can call and get medication assistance. Folks that can't get to their doctor's appointments, so you think they're not showing up because they don't care, they oftentimes don't have transportation. So we really, really use this team approach and really rely on our integrated care team, our social workers, to kind of meet the total needs of our members. And it's amazing the things they do. Something just so simple, like Karen said, we had a member who kept missing appointments. The physician's very frustrated, finds out he is in a wheelchair and didn't have a wheelchair ramp. Simple. Called our social worker, ended up talking with a local scout troop that needed a project. project was building him a ramp. So, I mean, just something as simple as that. Folks that miss their doctor's appointments because they're anxious because last time they went to the doctor, they were diagnosed with cancer. So every time they think they're going to go to the doctor, they're going to get bad news. We have our counselors talk to them. So it's just a really neat opportunity to just meet the entire needs of your members, and like Jeff said, help you. Let's see if I can do this without. So really this slide just speaks to, and again, since we're so new, we don't have a lot of data, but this is just basically the contacts that we have been able to make with our members. It just shows March, April, and May, the number of phone contacts, and it shows the bedside visits and the home visits. And what really kind of separates Mission Point, sets us apart from different other models, is that we do make the bedside visits and the home visits. And it's just a really neat way to connect with the members, their families, and kind of get the whole picture of what's going on.
All right, any questions from the health partners on the roles that they play? I think you can see they can make a difference and be an extension to your practice and really help out there. Another big component of Mission Point is our member services, and you do see this member services phone number right here. If you want to refer a member to Mission Point, you can call that number as well. It's a 1-800 number. They will connect with the Mission Point Health Partners in Indianapolis. So it's a great number to have. I've got some information out front on the table. You can grab a little card. It's got that number on there. I'm handing those out as I go out to the practices to make sure that they have that readily and available, because it's a quick, easy phone number to have and to use. You can also see with member services, they do a variety of things. It's not just calling, the members calling. They do a very wide range of things. They've got providers calling them. They've got members calling them. They have a Medicare expert to address the Medicare members and what they need, lots of questions and assistance with. One of the other things, though, I think that's really neat about member services is they can work directly with St. Vincent's on different campaigns. So we know that if our members have assigned primary care doc, our costs will be reduced as much as 33%. Is what the studies show. So because they're going to their physician offices, they're not using the ED as their primary care. And so we wanted to strive to get everybody signed up with a primary care doctor. So we have done a variety of campaigns with our associates to get them to sign up with primary care. Some other things that we've been able to do is look at rising risk members and being able to hook them up with a health partner through a campaign. Or maybe it's a screening. Maybe we want to screen everybody that's 50 and over to get a colonoscopy or mammogram, whatever that is. So St. Vincent's is able to use member services team to actually do some of these important campaigns. But if nothing else, remember this phone number. It's really key. Or my card too works as well. But next is clinical integration. I'm not going to spend a lot of time on this, but just want to kind of to highlight that you are in a clinically integrated network. Your contract is on clinical integration, and so as Mission Point, our responsibility is to provide that network to you to make sure that we help health partners to assist you in the care of your members, and then also to have that data. Now, unfortunately, we don't have a lot of data yet because the claims are still kind of coming in and trickling in. So it is our hope that in the next couple of months we will have that data to share back with you, so we can kind of look at some of the measures and goals that we want to achieve in the upcoming year. One of the things that when you're part of a clinical integration, we have requirements that we have to follow. And we have some needs for you as well that we want to ask of you. And again, I appreciate you coming tonight, because part of the clinical integration agreement is to attend the annual meeting. And so you all can check that off your list because you've done that tonight. It's important for us to be able to share information out. Some of the other things is on a committee. You may have been already asked to be on a committee, and if so, thank you for participating. When we look at population health strategies, we know the best way is to have some of the committees, and Dr. Sweeney will talk a little bit about some of those committees that we have in place already this year. When we look at, we're looking at quality metrics, we're looking at inpatient utilization, we're looking at keeping things within network and not sending things out of network when at all possible. And then there's compliance requirements that CMS requires us to do. So all those things are part of clinical integration, and just wanted to touch on those so that everybody was aware of kind of what those responsibilities are for Mission Point, and then also things that we feel are really important for you as well. I'm going to turn it back over to Dr. Sweeney, and he's going to talk about the committee structure that's in place today.
Thanks, Karen. So, Mission Point really is, from the comments that I made initially, that as we look to move toward value-driven healthcare, and we become an ACO and start to accept full risk, Mission Point is the Ascension and really the St. Vincent Health strategy for teaching us how to do that. I mean, we've done extremely well in the traditional healthcare model. We're not so good at the value-driven healthcare system. So Mission Point is coming in to help us with that, helping us get those skills about how do you improve the quality of care. Much of what you've heard already is about transitions of care. We know that much of the cost in healthcare, much of the waste comes from somebody leaving the hospital and then falling off the cliff, and not getting the follow-up they need just because that resource is not built in. And one of the other points that I think is important is how is this different from Anthem's care managers and Cigna's and everybody else we have attached to them. Mission Point, the role is technically the same, but Mission Point is our strategy moving forward. So they're going to be involved in a much bigger percentage of our patients. And they're more embedded in the processes that we do. They're part of us more than a lot of the other payers programs are. So we're going to get better at it as we do more with it. So let's talk about the committees, the opportunities for you to get involved. Now, we have 4 committees up here. We're going to be expanding the number of committees. These 4 committees are already have participation on them, pretty much, not completely. But the 2 structural committees are the network participation. This committee basically decides what new providers it would like in, who should that be, what type of providers are we looking for that would like to join that aren't already part of our network. The benchmarking in education takes a look at the data. We talked about one of the expectations is that we would have data that goes out on quality, on efficiency, and this committee takes a look at that and decides, are there opportunities for us to do better? Are there people who are doing very well that we should talk to specifically and find out what kind of processes they have in place? We have 2 clinical committees working. One's diabetes, the other is our preventive health care. The diabetes is obviously around diabetes. It works. We also have one within SVNG, and the 2 committees will be working closely together and trying to come up with standardization of the way we do stuff. Not only standard processes, but also standard services that we would provide around the system. And then preventive care. Are there systems and processes that we can have embedded in our current EHR, our current workflows that improve the overall care on preventive services? So there'll be more committees coming that we'd love to have you involved. So let's talk just for a second then about general principles of how you get better. Now, you would think this would be relatively intuitive, but what we find is that people don't always think about improvement the way that works. And what we're finding in full risk care, we have to get much more efficient. There's so much waste in healthcare. It's estimated that 50% of the time you spend taking care of patients is wasted time. It's fiddling with your computer or waiting for a patient or all these other forms of waste that I know frustrate all of you. So how do we get, a lot of the way that we do the better stewardship, the better efficiency is around taking the waste out of that system. So you're not looking for ER reports. They're already in your electronic health record when the patient shows up. So the way we do that, 3 basic steps. We take a look at the data. Now, what's the data telling us? For our diabetic care, how well do we do at taking care of diabetes? Who does well? What's important? And once you understand your data and you really get everything out of it that you can, you basically go for places where we're not doing well, we look for causes. And exactly why is it that we're having a problem here? Why are our A1Cs higher than they should be? And why are our patients going to the ED more than they should be? So if we recognize that a particular provider's got a high rate of ED utilization, what is it that's causing that? Or what is it as a system that's causing that? And then once we understand those two things, then we start talking about ways to make things better. But a good disciplined approach to improving the efficiency and getting better is about doing the first two things before you just start jumping at solutions. The Mission Point model we know works. It's a wraparound strategy for transitional care elements. That means that you get it as a bundle. It comes and it provides that wraparound care. And we know that as an improvement model that works around transitions of care. But what other types of things will we be looking at to improve the quality that we provide? So when you sit on these committees, this is how we'll be approaching it in a disciplined way. St. Vincent Health as a whole is working on taking what we've done great in the past and being more disciplined around getting better efficiency and improving the quality that we provide to our patients. Karen's talked about some of the tools that we have to use to help us. Analytics are always key. Remember, data was that first thing that we talked about. Analytics basically takes raw data that's in our systems and then puts it together in such a way that we can use it. So we can take a look at how well your A1Cs, it can tee up your A1Cs for you and give you information about them that maybe helps you actually provide better care. So Crimson has 3 different platforms. We've talked about them already. The Crimson, the registry component stores data and helps us report out so you can get better data. You guys haven't seen these data yet, but they're coming. Not just Crimson, but within St. Vincent Health, Optum is another analytics tool that we'll be having. It'll help provide much better data than we've had before. Crimson Care Manager is that tool that the health partners use, that they'll be able to actually track patients. Right now we've got inpatient Sunrise Clinical Manager on the inpatient side at St. Vincent, and we have various outpatient clinical records. They don't talk well to one another. The Crimson Care Manager is a tool that they can use then to at least document across the care continuum. And then finally, population risk management. We don't have a good predictive modeling tool prior to Crimson, so which of those patients are the ones that we expect that might get sick? It's surprising how well with statistics they can do to predict accurately who are the high-risk people who could be getting into trouble. So the Crimson product is really our first foray into predictive modeling. We'll be doing a lot more of that as time goes on, so we can be much more directive in who the patients that we're talking to. Okay, the Medicare Shared Savings Program then, remember we have 2 different programs that Mission Point's involved in, 2 different at-risk programs. One is one of our associates that all of you are involved in. You're all also involved in the Mission Point, or the Medicare Shared Savings Program. The one group that's not part of it, this is the primary care of this component, is just St. Vincent employed physicians. If you're in a line but not employed, at this point this is not something that you're part of. But, this is for Medicare, the Medicare Shared Savings Program, 3-year agreement with CMS. This is a national program, you've probably heard of it. We have 33,000 beneficiaries, so this is really our first attempt with Medicare to try to learn how to do this. Currently, we have no downside risk to this program. Basically what that means is if we do poorly, it's not going to hurt us financially. Remember that first slide where we talked about 50% at risk for Medicare in the next 2 years. So Mission Point's helping us get good at this. So in 3 years, when that number starts to rise and we do start taking risk, that means if we perform poorly, then we're not going to do well. We're going to take a financial hit for that. Right now, on the outpatient side, in this type of a population, we won't have any downside risk. So first year is baseline reporting only on quality measures. Then we will have an upside potential to that. That means that if we do well, we can actually get some money back from Medicare. Now, you can see on this column over here, this basically has our actual expenditures per beneficiary. So the way we look at this, and the way that you guys will get more skilled at looking at this, is thinking about how much is it costing us it's pretty simple. How much do we get in? How much is it costing us to take care of the patients? The difference is, is basically stuff we get to keep to improve our overall processes or profit. So our actual expenditures as of April 1st, 2015 is $8,589. Now, this is Medicare patients. So this is obviously a more complex patient group. That number is pretty low, honestly. Much to our surprise, the care that we provide to these patients here at St. Vincent were relatively inexpensive, which I think surprised many of us, because we would have thought that we provide high quality care, but not necessarily the least expensive. So that's great news for Medicare, great news for our history of providing efficient care. It's not so great news in that for us to go down, and they basically take a percentage down, we've got to go from very good to great for us to realize any shared savings. So there's a benchmark that a Medicare sets. It's basically a target, but then they say if you go beyond the target, there's a minimum savings threshold. And many of the at-risk programs are like this. There's a threshold the cost per member per month, if you can get below that level, then you'll start to share in the savings. And then when you take a look at the amount of money that we have in this program, even a 1% savings is a lot of money. Okay, so the way we get smart about that is we talked about, we take a look at the data, we look at what are the causes, how do we drill down to the data, then what are the causes for our misses or our opportunities. So if you take a look at the data and you start to drill down into what it means, you want to break it out. So the four basic areas: inpatient, outpatient, professional, and ancillary. And you take a look at the relative cost. So how much for these patients, for the average patient, how much of that $8,000+ goes to inpatient, outpatient use forward? You can see acute hospital admissions is the largest, no surprise. Outpatient facilities, this includes our ER utilization, is second. Prescription Part B drugs, you can just kind of go down through here the various costs. E&M codes is only $867, interestingly enough. So, E&M codes are not where you're going to see your savings here. It's in managing like ER utilization, hospital admissions. If somebody comes to the hospital, the best way to cost a lot of money is having them go home and then come right back again. So, one of the key things that we look at are readmission rates. There's another measure called ambulatory sensitive conditions, things like diabetes, that we really shouldn't be admitting to the hospital for diabetes itself. So what is our rate of admissions, and what is our cost for these ambulatory sensitive conditions? And these are the type of committees that we will be, over time, as we get better at this and recognize areas of opportunity, that we'll ask you to be involved in. So this is another, this graph depicts another area of focus for Mission Point. We know that patients, as we talked about, as people get more complex, their chances of having increasing costs go up. No big shock there. What the red line depicts, though, is what happens if they have psychosocial comorbidities. So you add on top of that lots of medical issues, but then you put in there that they're also depressed, or they've got problems with psychosis or alcohol or drug abuse. And that cost, we know, goes up significantly. So Mission Point is very good at identifying those patients and then getting involved with a lot of the psychosocial stuff. So the metrics, this is ACO 33. So for those of you that have not looked at this before, this is across the industry. This is what, the ACO 33 are the main metrics that pretty much everybody looks at. Most of these are primary care driven. They're outpatient metrics primarily. Medicare also manages us on the inpatient side, but on the population health level, there's what are called CG caps. Now, most of you that do inpatient medicine are familiar with HCAPS. HCAPS are the inpatient patient experience or patient satisfaction measures. There's an outpatient one as well, CG caps. So one of the things that we will be working on and looking at are our CG caps, our patient experience, and you can see a list of them. How well did your doctor communicate with you? The R means in this first year, the year we're in now, that we're just reporting, and then P means it's performance related after that. So CG caps are our patient experience. Care coordination deals with issues like the readmission, that ambulatory sensitive condition that I talked about. SNFs is a big one. One of our big overspends. So if you take and you look at, our inpatient cost is high. It's our highest individual area, but actually if you take a look at our inpatient cost relative to what you would expect, it's not that high. So where are we out of line with what you would expect? Well, SNFs is one of our skilled nursing facilities. Our cost is higher than you would expect, and there are a lot of reasons why that is, but one of the opportunities then is for us to take a look at our SNF care within care coordination and manage that better. Things like contracted SNFs, working with a small number. We have, if you take a look at the discharges coming out of Indianapolis to skilled nursing facilities, we discharge like 100 different skilled facilities coming out of Indianapolis. So, you know, our top 15 we do real well with. It's the other 95 or the other 85 that we struggle with. So CG caps, the medical record, this is meaningful use stuff primarily. It's all pretty much automatic. And preventive at-risk stuff. So these are the things that you would expect: the colon cancer screening, mammography, diabetes-related measures. So these are basically the ones that that CMS, that most of the payers actually have a very similar list in terms of the quality metrics that we measure, that we manage, that we look for opportunities. Okay, Karen.
And just in closing, one of the things that, because we do have an ACO, we do have compliance responsibilities that we have to do. And so when we look at all of those things, we do have a corporate responsibility officer, Becky Lovelace, and she's located in Nashville. She's our corporate compliance officer, and she is responsible to make sure that we're all compliant. So big job for her. Glad she's doing it, not me, but that is her role. And so as you're part of our network, it's our responsibility to make sure that you're aware that we have this in place and we're working to make sure that we are compliant. Part of this is that you may be asked to, we may send you information on education or training that you may have to look through. I don't think we'll have actual meetings on it, but we'll find some other unique ways to get the information across to you, just so that we are compliant with CMS on those measures. And just to highlight, there are policies out there that you can go view on your own if you'd like. But one of them that I think a lot of the offices will be ecstatic to hear about is that no longer, as of November, all those beneficiary letters no longer have to be handed out at each visit. And that's been something that has taken a lot of time from the offices, that they have to make sure they hand that letter out. And I get calls and they're saying, I need a new box. I mean, I'm out of boxes. So if you have a high Medicare population, that will be a relief for your practices that they no longer have to do that. So more information will come on regular training and requirements that we have to do, but St. Vincent's and Becky Lovelace are working very closely to make sure that whatever requirements CMS has, we're adhering to them, and that's what's important. So just wanted to make sure you can share that you knew we are in compliance and we're going to stay that way. So.